A 58-year-old man presented to us after having an incidental cerebral aneurysm identified on headache workup.
The patient was a non-smoker, had a history of hypertension and multiple lumbar surgeries. His mother had 2 cerebral aneurysms.
Review of MRA imaging revealed a left MCA bifurcation aneurysm.
Left ICA angiography confirmed the presence of a 5 mm left MCA bifurcation aneurysm. Given the wide neck, the relatively young age, and the patient's generally good health and strong preference for treatment, microsurgical clip reconstruction was offered. The patient was positioned supine with the head turned 20 degrees towards the right. A left common femoral arterial sheath was placed. The incision was made from the midline behind the hairline to the zygoma in a curvilinear fashion. After exposure, the sphenoid wing was drilled flat to unitize the anterior and middle fossa. Here seen is the exposure after craniotomy and dural opening. The temporal lobe is to the left of the screen, the frontal lobe to the right of the screen. This is a left-sided approach, and the sylvian fissure is in the middle of the screen. Dissection of the sylvian fissure is started first with a sharp 11-blade knife. Sharp dissection with microscissors is used. Careful use of the suction to allow for retraction to place arachnoidal bands on tension before cutting is done. Care is taken not to injure the underlying vessels within the fissure. Careful use and judicious use of retraction and blunt dissection is employed to allow for careful dissection of the sylvian fissure. Care is taken to avoid peel encroachment and brain injury. The use of a cotton ball can be useful to allow for both retraction and a wider plane of suction. Stepwise and coordinated advancement of the suction allows for expeditious and atraumatic dissection. Here the thick superficial layer of the vertical sylvian fissure is cut, allowing release of the frontal and temporal lobes. Attention is now turned towards deep sylvian fissure dissection and exposure of the aneurysm. Distal MCA branches are followed deeper into the sylvian fissure. And now seen is the MCA bifurcation aneurysm, the left M1 and the M2 divisions. At this stage, the left M1, anterior and posterior M2 divisions have been identified, as well as the left MCA bifurcation aneurysm. A temporary clip is placed on the left M1 to allow for softening of the aneurysm and for further final dissection. A tandem clip strategy is employed. First, a straight fenestrated clip is used to clip the proximal aneurysmal neck, with the fenestration communicating the left anterior M2 origin. A straight clip is then stacked on top of this clip to allow for closure of the remainder of the neck beyond the anterior M2 division origin. The temporary clip is then removed, and ICG video fluoroscopy confirms patent filling of the M1 and the efferent divisions. Intraoperative angiography confirms aneurysm obliteration and maintained filling of all MCA branches. The patient's postoperative course was complicated by a single seizure in the immediate postoperative recovery area. The patient was given antiepileptic medications
and subsequently did well. At 5 weeks, he returned to clinic doing well with no headaches. He complained only of mild intermittent double vision, which was improving, and had returned to work as a contractor. He suffered no further repeat seizure episodes, and his surgical wounds were well healed.